grant cycle 7 is also underway. So kindly, as much, let's take this conversation into the space where we are writing to strengthen our peer educator program. And I must say, from our experiences in Zimbabwe and from the work that we have been doing with key populations, a peer-led program is the pillar or the tenant of HIV programming within the key population space. So buckle up and let's take the next presentation from Pari. Over to you, Pari, if you're ready.
Thank you so much, Humphrey. Thanks, everybody, for joining in. A special welcome to Global Fund PRs and SRs who are joining in today. And of course, to all the champions of the South-to-South Learning Network. Like Humphrey said, we really hope that some of the learnings from here get into our COP preparation, our proposal writing, so that we can make best of these sessions. So my session is to provide global guidance on community-led outreach, including role of peer outreach workers. Next slide, please. So many of you may have attended the GPC webinar where presenters presented the WHO consolidated guidelines, which was launched in 2022. So these are the new guidelines. The last guidelines were revised in 2016. And these guidelines of 2022 talk about the essential health intervention package, but also very strongly talks about enabling interventions and interventions for broader health, which may not have direct impact on HIV, viral hepatitis, or STI, but are highly recommended to ensure that key populations use the highly impactful health interventions. Next slide, please. As the new guidelines have come in, the implementation tools that were developed in 2014 still hold good. So we have 4 implementation tools for key populations: the sex work implementation tool, the MSM implementation tool, the trans population implementation tool, and the drug users implementation tool. So while WHO has been providing the what of the key population program, these implementation tools provide the how, and these tools are available in English, French, Russian, and Spanish, and have been developed with very strong participation by key populations themselves. Next slide, please. In addition to that, there are other guidance. One of the guidance is the Key Population Trusted Access Platform, which also provides the how of implementing a good key population program. And if you press it again, Lulama, it emphasizes a lot on engaging community with continuous key location presence and strengthening outreach, including microplanning. Next slide, please. And the latest one also to come out is the virtual HIV interventions, which provides guidance on how to do interventions in virtual spaces. And even this guideline actually talks a lot about peer facilitation and peer. So I'm just showing you these guidance. That one of the common thing in all of these guidance, of course, they're global guidance, and national programs and implementing partners are expected to follow these global guidance. But on the common theme in all of this guidance is community-led outreach and community-led and community participation in the key population programming. So that's a common thread in these guidelines. Next slide, please. So as we talk about community-led outreach, one of the guidelines very clearly talks about, actually it's the main personal interface between the program, which many of us implement, and the majority of the key population community. A community-led outreach also is promotion of services, referrals linking the community to condoms and loop supplies, testing, counseling care, treatment, and of other sexually transmitted infections, or hepatitis, etc. It's also an entry point to strengthen community leadership and an entry point to strengthen community-led crisis response, and other structural interventions. Next slide, please. So when we talk about community-led outreach, it means simply that key populations reaching out to other key populations at their preferred location during their preferred times with programs and services that address their needs, rather than waiting for the key population to show up in the clinics or drop-in centers or offices. Next slide, please. And we all know why outreach is important for key population. Its services and programs are not always accessible to key populations. It may not be available at the right time and the right place when they need it. Often, key populations are new to an environment because of mobility and migration and may not be aware of local programs and services. There is huge amount of stigma, discrimination, violence that we know that happens with against key population, and that is a barrier to access to services. And risk-reducing commodities like condoms, lubes, clean injections may not be available at the place and time where risk takes place. So it may be available in an office, but not at the location where risk takes place, and hence outreach is important. And vulnerability factors are intensified at the locations where key population members stay or work or inject or even cruise. I saw a quick message on the chat that Portuguese interpretation is available, colleagues. Sorry for the delay, but you can go to your the interpretation channel and choose your language. Next slide, please. Again, we know that outreach has to be led by community because it should be based on the needs and experience of the key populations and not what the program thinks. Sometimes the way the program thinks and the way the community thinks is very, very different. And we cannot motivate or encourage the community to access services if we do not think the way they think. And community-led outreach, also one of the objectives, as I had mentioned earlier, is to empower key populations to protect themselves rather than focusing on services provided by the program, and also to stimulate community empowerment to create a collective identity and solidarity. Next slide, please. These are some of the key principles for successful outreach, as mentioned in the global guidance. Credible, trusted outreach personnel, so peer educators, peer outreach workers, peer supervisors become an important cadre for community-led outreach. It should be oriented to community situations and needs, have clear objectives, and of course, maintain confidentiality. But at the same time, understand that the community is not a homogeneous community. There's heterogeneity based on where people practice, based on gender identity, based on age, etc. Next slide, please. The global guidance talk about these 4 steps when we are implementing a community-led outreach. One is mapping to design an outreach strategy. The other one is recruiting and training. Third one is conducting micro-planning to implement, manage, and monitor effective outreach. And the last one is to foster leadership opportunities to outreach team. I'm going to talk about the global guidance, but Janet and Primrose are going to come after me to talk about how some of these are actually getting implemented in countries. So these are not necessarily just guidance and theoretical frameworks, but actually can be practiced based on the country context. Next slide, please. So the first step in any key population program is mapping the community. People do key population size estimation using multiple methods like capture, recapture, or multiplier, or programmatic mapping. But once we have that data, it is still very important to engage the community. If KPSC hasn't engaged the community, it's important to also engage the community, local community, to map their locations. And these mapping of the location can be physical or virtual locations, especially where key populations meet sexual partners or inject drugs. And then there are several tools that are available, and some examples are given over here, which can be used to do mapping with the community. Along with mapping, it could be very important to engage with consultation with the community at the local level. And because all of these processes actually help in building rapport with the community and to identify an outreach team which will be best suited to cater to the key population needs in those specific locations. So a key population size estimation that is done at a district level or a county level or a national level is a little different from mapping the locations or hotspots, whatever we can call it, at the local level, because the need for that is more community ownership and understanding the community needs, but also that helps in identifying the outreach team that could be selected in that location. Next slide, please. So once the mapping is done, based on the mapping findings and community-led consultations, a community-led outreach system can be developed. Normally, an outreach structure includes peer outreach workers. Different countries call them differently, but they are peer educators, peer outreach workers. You'll hear Primrose also calling them micro planners. And then there's also another structure which is on top of the peer outreach structure, which is more of a supervision structure where you call them peer supervisors or outreach workers. Normally, peer outreach workers or peer educators are part-time and they put few hours in a day into the program, but peer supervisors or outreach workers can be full-time staff, but both generally belong to the key population community. Each peer educator is selected based on their contacts from the location where they normally operate from, hence the mapping is important. If a sex worker like me operate in a location A, and I have contacts in location A, I come to location A almost every day to do sex work, I would be made, if I agree and if the community agrees and if I qualify, I would be made a peer educator in that location A rather than location B or C where I don't have any contacts. So each peer outreach worker is allocated locations where they take responsibility to support the key populations in those locations. Though peer educators should be compulsorily from key populations, in reality, key populations can be selected for any of the positions based on their capability and skills. And if non-KPs are recruited for other positions like supervisors or outreach workers, then peer progression plan, we'll talk about it, should be developed. Next slide, please. So when we're designing a peer outreach strategy, a peer ratio is very, very important. So how many peer educators we need to select to reach how many key populations, right? Again, Janet will talk about when she talks about the national guidelines in Kenya. Primrose will talk about what they do in their implementation program in Zimbabwe. But one of the studies that was done in Kenya found that if the KP peer educator ratio is less than 90 for sex workers or less than 60 for MSM, then the program sees improved outcomes like outreach contacts or regular clinic attendance increases if the ratio is 1:90 or less for FSW and 1:60 or less for MSM. People ask, why is the ratio for FSW more than MSM? Obviously, it's a matter of context, but in many contexts, there are more FSW congregating in one location than MSM, and MSMs are a bit scattered out, or PWIDs are a bit scattered out. Hence, you need maybe more peer educators to reach the key populations based on typology. However, we may sometimes underestimate the value of the ratio, but this ratio is very important for impactful outreach, but at the same time for budgeting when we're looking at proposals or programs. Similarly, for outreach worker, the ratio is 1 outreach worker or 1 supervisor per 5 to 10 peer educators. And beyond 10 peer educators, it becomes ineffective because then the outreach worker is very stretched and cannot really provide good supportive supervision. Next slide, please. And we know the difference between what the role of a peer outreach worker is and what the role of an outreach supervisor is. So I won't get into that, but I just also wanted to say that the the responsibility of the outreach team is just not only going and meeting key populations, but is also to provide feedback and also do regular gap analysis and reporting. And in an ideal situation, the outreach team should be considered as the manager for the location and hotspot. So it's not about them coming and reporting to the project, but them using data at the local level to understand which key population they have to reach more intensively and which key populations have not come to clinic and needs the follow-up, etc. Next slide, please. Recruiting and training the outreach team, of course, is critical. It's important to develop terms of reference. There are standard terms of reference in all the global guidance that I had shared earlier. But in some implementation level, in some countries also like to engage local level community members in selection of peers, which can be quite participatory and useful. But guidelines for recruitment, retaining, and assessing and promoting peer educators through the national guidelines is important because implementation in a country is done by various implementers funded by different funders. So some standardization at the national level and at the sub-national level is important. A training curriculum to train peer educators, a standard training curriculum, if it's there, it helps. To train peer educators and outreach workers. And the one thing that I would also want to say, the last 2 points about remuneration, a peer educator is not free service and needs to be remunerated and needs to be budgeted in our proposals. And at the same time, a peer educator should not be a peer educator all their life, right? There should be plans for peer progression. Next slide, please. And you'll hear more about how practically it is done in the next 2 presentations. When we talk about an outreach team member, we also say that they should be active key population members, especially peer educators need to be active sex workers, active gay, MSM, active drug users, and active trans, I don't think there's something called active transgender, but should belong to the transgender community. At the same time, if you have a supervisor, it's in some contexts, it is very fine to have active member of the community. In some contexts, like PWID, they do prefer ex-users, but that could depend on the implementation partner and the country making those policies. They should be knowledgeable about local context. They should have a good social network, and they should be accepted by other key populations. They should be able to maintain confidentiality and, of course, good listening skills, leadership skills. Sometimes when I read the qualities of outreach worker, it feels like they should be actually the director of the organization with all these skills. But that is what is mentioned in the global guidance. Next slide, please. So remuneration is very important, and I think we need to take this into account. And so the global guidance, especially the key population-led guidance and implementation tools, do say that community outreach workers should be remunerated for their work. But they do also say that certain approaches can be problematic, like paying outreach worker for each individual they persuade to come to the drop-in center. So there are sometimes we do pay outreach workers and peer educators an incentive, like if you bring two other key populations to the clinic, you are going to get 400 shilling more or $2 more, etc. So the global guidance do say that this can be problematic if you do more incentive-based payments, because then that can distort the demand and lead to even coercion. So the guidance say that less coercive and more effective incentives include, of course, honorarium or salary, but also phone credit, non-monetary gifts, leadership opportunities, and recognition that is not linked to the number of sex workers who are brought to the program. So some examples are, of course, paying a salary, paying a stipend for extra time, maybe doing training, or reimbursement for travel or mobile airtime, etc. So you can decide what works for your country and what works for the community in your country, and how this remuneration package can be planned in consultation with the community. Next slide, please. Conducting micro-planning, and you will hear more from Primrose, is very important because, as we had said earlier, the a key population community is not homogeneous and the outreach needs to be differentiated. Though we talk about differentiated care nowadays quite a bit, but we have been talking about differentiated outreach for a very long time. And differentiated outreach can be based on typology, based on client volume, age, timing and day of operation, gender identity, duration in sex work, type of sex, experience of violence or alcohol. Different key populations need different services, and micro-planning helps understand what a specific geography or location and what specific individuals or key populations who practice within those locations need. And that's why it's called micro-planning, because you plan at the micro level, but it also helps to manage and monitor effective outreach. Next slide, please. And I won't go into detail about purposes of micro-planning because in Primrose's presentation you'll see. But one of the most important advantage of micro-planning is that it helps the peer outreach workers to transition from passive data gatherers to active site managers. And they can plan, they can identify and profile the community members that they're responsible for within a location, and plan for programming and services for those key populations. And they also then become advocates for the needs of the key populations within their allocated locations to the program. Next slide, please. And there are several micro-planning tools that can be used for planning, implementation, and management. And they are simple, can be used by non-literate population wherever is necessary, and actually empowers the key population, outreach workers and the key populations. Next slide, please. The key consideration for micro-planning or any of the outreach is data safety, because sometimes through these processes, we create charts, we create visuals, etc., which need to be kept in a confidential space, because we know that key populations are still criminalized in most countries. And also microplanning is not a one-time activity. It has to be done on a regular basis because change happens in locations, change happens in people, in the population, the way vulnerability. And data generated through microplanning should link and validate data generated through the facilities so that there's a link between outreach and the services that are provided. Next slide, please. Fostering leadership is very important. As I said, I don't think we should consider peer educators as peer educators for life, and leadership can be fostered through training and mentoring opportunities, through peer progression, opportunities for program management and leadership, and involvement in program monitoring and planning. And we do see programs these days which are not only led by key population networks, but also we see a lot of positions in a program are managed or are given to the key populations. Next slide, please. So this is my concluding slide, that community-led outreach is an essential link between community and the HIV prevention, care, and treatment offered by a program. It empowers key populations to draw on their first-hand knowledge of vulnerability and risk to problem solving with the members of the community, strengthen access to services, and making HIV prevention, care, and treatment viable. Outreach workers build rapport with other key populations, understand their needs as individuals, and on a regular basis provide them or link them to appropriate high-quality services. And by monitoring the relative vulnerability and risk of each individual key population, community outreach workers also supply the first level of data collection for the program. You're going to hear, I'm going to hand over to Humphrey, and you're going to hear a lot about practical experiences from Kenya and Zimbabwe in the next few presentations. So over to you, Humphrey. Thank you.
Thanks, Perry, for that very exciting presentation. Quite a lot of practical examples of what countries and programs should consider in implementing their peer outreach models, and very difficult circumstances that they have to contend with harmonizing remuneration for example, and particularly ensuring that, peer outreach workers don't maintain as peer outreach workers. We all have aspirations in life to grow and to do more and to contribute to our family life and all our satisfaction. Without much further ado, I'm going to invite our second speaker, Janet Musimbi-Mbole from Kenya, who's going to share a national perspective of their outreach program in Kenya. Janet, if you're ready, over to you. And colleagues, kindly note that all these presentations are going to be shared with you just after this, when the meeting has been finished.
Okay, good afternoon. Apologies, I seem to be having a problem with my video. As said, I'm Janet Musimbi. I support the national program in Kenya, and also with NSDCC, and I'll be able just to share our community-led outreach and peer education program. Next slide, please. So just a brief overview, just basically looking at one of our vision and our goals, just basically ending AIDS as a public health threat by 2030. And we've made great strides towards this, whereby we have been able to see a reduction in our HIV prevalence that is now currently at 4%. And just maybe we've been able as a country just to look at which pockets do we still have infections coming in. And we find that where our key challenge is right now is that we still have about 64% of our new infections among adults, which occur among the 15 to 34-year-olds. And then also just a key concern for us as a country is basically the adolescent and young people, where we have 34% of new HIV infections. Next slide, please. Among the key population, one of the key things that we've been able to look at is just be able to look at HIV prevalence through an IBBS that was conducted in 2010-2011. And we hope as a country that we'll be able to conduct another IBBS this year, so that then we'll be able to get current data on our HIV prevalence. But based on that, one of the key things that we know is that as a country, we have population size estimates, where we have an estimated size of 197,000 female sex workers. We have about 61,650 MSMs. People who inject drugs, we are about an estimated 26,000. And for the transgender population, we have around 4,370. Next, please. So when we look at our HIV programming in the context of the key population, Kenya has a mixed epidemic where we have both concentrated and generalized. And one of our guiding document, which is the CAFS2, identifies them as a priority population in our HIV response. When we look at key populations in the country, we have female sex workers, men who have sex with men, the transgender people, and the people who inject drugs. And as indicated, one of the key reasons why we prioritize this population is because of the high estimation that is there among them, the high HIV prevalence among them, and also in the context of the country, sex work, drug use, and same-sex relationships are criminalized. And therefore, we need to find a way of how best then do we ensure that we are able to reach out to them with services. Next, please. The program in the country is led by the Ministry of Health through the National AIDS and STI Control Program, and NAC, the National AIDS Control Council, which now is known as the National Syndemic Disease Control Council, and they spearhead and lead the program at the national level. At the county level, this is led by the county offices through the CASCO's office in each and every of the 47 counties that we have. We do a combination prevention approach for the program, where we look at biomedical, behavioral, and structural interventions that we have. NASCOP and NAC are responsible for providing strategic direction, ensuring that we have standards for providing services to the key population program, providing technical support and coordination of the program, ensuring that evidence is generated for the program, mobilization of resources, and having an enabling environment for the programs in the country. At the county level, the MOH ensures there's efficient and effective implementation through the implementing partners and that they coordinate the program at the county level. Currently in the country, we have 42 counties that are implementing the key population programs out of our 47 counties. And this is done with funding support from the Ministry of Health. We have PEPFAR, Global Fund, and other donors. Next slide, please. So I have talked about the national, the coordination structure. And one of the things to note is that the program was established within NASCOP in 2009. And that through this, we had the formation of a multi-sectorial technical working group with membership from the key populations, from the implementing partners, donors, and developmental partners, and that they meet on a quarterly basis, basically to understand and discuss the program. And that with the devolution that happened in the country in 2015, then this was then devolved to the county level, so that at the county level, we also have county-led key population technical working groups that also discuss issues around key population at the county level. All technical working groups then have subcommittees that would discuss specific technical issues. So as I've said, we have the National KP program that is led by NASCOP and NAC, now known as NSDCC. And then we have the National KP Technical Working Group. Then we have the County KP Technical Working Group. We have a technical support unit that then gives support to the national program. And then at the national KP TWG and also at the county, we then have the different subcommittees then discuss the different issues that affect key populations. Next slide, please. So for the policy environment for the program, as I indicated that sex work, same-sex relationship, and drug possession and use is criminalized. However, the key populations were first prioritized in the National Strategic Plan since 2009. And therefore, based on this and based from national guidance and even guidance from WHO, looking at the sex workers implementation tool, we were able then to develop national guidelines for HIV and STI programming with key populations in the country in 2014. We also were able to have a national policy for prevention of HIV among key populations in 2016. And then further, due to emerging needs of, especially when we realized we have young KPs in the program, we were able to develop our guidelines for them in 2018. And then for transgender people, a guideline was then developed in 2020. Based on this, we ensure that, and based on the guidelines that we have, we ensure that the coverage and effectiveness of service delivery, one, will depend on the peer education program that you have and the outreach programs. And all these have then been stipulated in our national guidelines that spearhead and lead us as a country on how best to implement the key population program. Next, please. So, as Humphrey actually indicated in his opening remarks, community outreach, and especially it being prioritized with peer educators and outreach workers, is the backbone of the key population program. We know that peer educators who have to be key populations themselves, and they're selected from mapped venues. And in many cases, they are KP communities who visit those venues, and therefore working together with the key populations in those venues, they're able to identify peer educators that feel will be able to serve them better. One key thing, and this is something that Paria has also just alluded to based on the guidelines. In our guidelines, we have peer educator ratios, and they're very specific in our guidelines. For female sex workers, one peer educator is supposed to reach out to 60 to 80 female sex workers. An MSM peer educator is supposed to reach between 30 to 40 MSMs. A PWID peer educator is supposed to reach out to 30 to 40 PWIDs, while for the transgender people, a peer educator is supposed to reach out to 30 trans people. We also have in our outreach model, the supervisory cadre of the outreach worker, which is very critical. And this is clearly outlined in our guidelines that showcases that one outreach worker is supposed to supervise and support 5 peer educators. In our guidelines, our outreach workers who are also KP interact with the peer educators on a regular basis to review their performance and support them in planning and monitoring the activities that they do. We find that in our guidelines, there's a clear laid out structure where we encourage that peer educators who perform well, there is a progression way in which they can then become outreach workers. So peer progression in our guidelines is very clearly spelled out on how best to ensure that we have progression of our peers in the program. Next, please. So this is basically just the picture of our outreach team, where we have peer educators who are supervised by an outreach worker, and then we have either a supervisor who is a program officer or a coordinator who then supervises the whole outreach team structure. Next, please. Pari has talked about enumeration. And in our 2014 guidelines, we clearly defined and clearly laid out what the enumeration would be for the different populations. For example, we have that for outreach workers for the FSW, MSM, and transgender program was between 10 to 12,000 shillings. For the peer educators, between 3,500 to 4,500 Kenya shillings. For the PWID programs, for the outreach workers, it was between 10 to 20,000 shillings. And for the Pathfinder was between 3,500 to 4,500. Please note that we're giving just guidance that these were what was stipulated in the 2014 guidelines, but due to the changing environment that was there and based on different TWG meetings that we had, a decision was made where, for example, for the peer educators, the enumeration was changed to between 6,000 to 7,000 Kenya shillings. In addition to all this, our implementing organization also offers stipends for travel or airtime. And the county is planning to revise the national guidelines, and hence this remuneration will be further revised. Thank you. Next. Peer education being the backbone of the KP program, it is very imperative that we ensure capacity building takes place. This is basically a critical aspect of the program. And what we have as a country is that we have specific cadre-wise training. We have trainings for the outreach team where we target the peer educators, the outreach workers, the advocacy workers, the paralegals. We have outreach that is specifically for the clinical team and also for program management. Even as much as we have trainings that do take place, these trainings, we do have the role of the national government that comes in and ensure that we have trainers of trainers being trained, who then cascade these trainings to the different implementing partners and at the county level as requested. Refresher trainings are also very key for us, for the outreach team. And we always encourage partners, and partners have been ensuring that they do refresher trainings for the outreach team, because based on situations that are arising, the different landscape that is there in the HIV prevention program, the peer educators and the whole outreach team needs to be updated on what is happening so that then they're able to effectively implement peer education for the key population program in the country. We have capacity building plans, and these are developed on a quarterly basis, and all trainings that are conducted by the country, certification is done by the national program. And there you can see some of the manuals and the modules that we have for the different key population. All our trainings are specific. We have specific trainings for PWADs. We have the specific trainings for MSMs. We have specific trainings for female sex workers, and we also have trainings for transgender. And even further down, we've actually, even for the PWAD, we even have had trainings that are there specifically for the women who use drugs. Next. I'll not belabor on this slide because Pari has really talked about it. We also really emphasize on micro planning, because this helps plan outreach for the program. And in the guidelines, we have set and indicated the set of tools that will help a peer educator plan for their outreaches at the hotspot. They basically address individual needs of the key population in these hotspots, whether physical or virtual, and it enables the peer educator be able to cluster his or her hotspots, know the names of the key population in those hotspots, and then understand their hotspot, whether the key population are homogeneous, understand the peak days and the peak times that they are supposed to be able to go there and provide services or reach out to their peers, and also understand quantification of how many and how much commodities do they need for the peers that they have. So all this, as Pari indicated, we ensure that our peer educators are able to do the site load mapping, site analysis, contact listing, and contact form. Things like contact form is filled once. The site load mapping, the site analysis, and contact listing, this is done every 6 months because things change in the sites. A peer plan and peer calendar and the opportunity gap analysis is done on a monthly basis at the partner level. Next, please. So basically, as a country, as the national program, NASCOP together with partners developed a set of 12 standards for peer education. And this was basically to ensure that coverage and service delivery quality across programs is maintained and is applied by all partners implementing the key population program. Ensuring that capacity building of outreach team is done using national curricula for all. And that indicators were also developed to monitor outreach and the work done by the outreach team. And all this information and all this performance for the outreach component is shared with partners, with the community, with donors during county and national technical working group meetings on a quarterly basis, during peer convention forums with the key population community on an annual basis, during an annual stakeholders meeting that is done annually, and also during donor meetings that are done quarterly. We also ensure that during our routine data quality assessment and during supportive supervision, the checklist that is used has a section on peer education to be reviewed at the program level so that to be able to support programs, ensure that they are within the standards and the guidelines that have been set for peer education. And the national program then holds advocacy meetings with donors to ensure that the guidelines in place are followed, especially after we have identified where gaps are. We are then able to just advocate and pick this up with the donors to ensure that our key population program maintains the standards that have been set in the guidelines. And there is just an example of our supervision tool that looks at the outreach component in the program. Next, please. So finally, managing our peer education, I've already discussed this. This is through the established coordination mechanism, which is at the national and county level, through the technical working groups and subcommittees, and they meet on a quarterly basis and review progress. Through allocation of the counties to specific donors to avoid duplication of peer educators, and in so doing, we ensure accountability in the work that is done. We have quarterly donor meetings to review progress using data and joint solutions to address gaps in outreach. I've talked about the annual peer convention so that we are able to receive back community feedback from the key population to understand where our gaps are and better improve the program. And then after the peer convention, we usually have an annual stakeholders meeting, basically to address the critical program gaps and plan for innovations based on feedback that we got during the peer convention. And we have the technical support unit, which is embedded within the National Key Population Program to provide TA and support our programs. Key to note is that for the peer education and outreach component, data that is routinely collected through the Kenya Health Information System, we have indicators that are also inputted in the KHRS that are specifically there to track outreach, looking at, for example, what our size estimates are, how many peer educators we have, how many outreach workers we have, looking at the work that they have done. So we do have indicators that specifically track our peer education program in the country. Thank you. And back to you, Humphrey.
Thanks a lot, Janet, for that presentation. And without much further ado, I really want to invite Primrose, to come immediately after your presentation. We take the 3 presentation and get into a robust discussion. I can tell from the chat people cannot wait to start the conversation, but I also encourage the presenters that have presented, Pari and Janet, kindly look through the chat and start interacting with colleagues on some of the issues that they are bringing up. Just to make sure that we are ahead of time and we're keeping the track, I'll invite Primrose. If you are ready, if you can go ahead with your presentation.
Thank you, Humphrey. Good afternoon, everyone. So just to start by saying that nationally, we have a similar infrastructure in Zimbabwe to the Kenya program, with the Ministry of Health and the National AIDS Council coordinating. And there is a technical support committee that sits within these 2 institutions. We also have the key population forums nationally and provincially. So we have that similar structure. And I'm going to come down to looking at the implementing partner perspective, and we're an implementing partner. Next slide, please. So it's just an outline. I will look in some detail at the program that SESHA implements and how we have integrated services within that for key populations. I will go into quite a bit of detail on the micro-planning processes and how we have scaled them up and tried to ensure that there's risk differentiation in the peer support that's provided, and then explaining within our local context what these roles and responsibilities look like. I will also talk about self-help groups that we incorporated in this peer outreach. And then in terms of progression, what our career pathways that we have defined for community cadres are. Next slide, please. So just a little bit of context. The last sort of prevalence estimates for female sex workers with HIV in Zimbabwe are 57.5%, and incidence is high. It's about 20 times that in the general population, and it's between 5 and 10%. The last size estimate nationally was in 2017, so we're due for an update, and there are plans ongoing for that at the moment. The last size estimate was 45,000 female sex workers. And as I said, we are an implementing partner with Ministry of Health and National AIDS Council, but we are implementing on a national scale across all 10 provinces in Zimbabwe. And we provide services to sex workers in their diversity, female, male, transgender. And we are operating in facilities that are co-located within the public sector. And we reached 38,000 in 2022. Next slide, please. So just having a look at what it looks like in terms of the service entry points. We have implementation sites that are within clinic facilities in major borders and towns. We also have along highway corridors and within major cities, what we call mobile sites. So they're local, mobile, and highway sites. And then we have 10 drop-in centers. And 6 of these are specifically for younger sex workers. The way we operate within these service delivery points is with this hub and spoke model, where teams will be based and then they do outreach into the communities that is led by the peers that we work with. And services can also be accessed at facilities when SESHA is not there, and there are also other implementing partners that work with Ministry and NAC. Next slide, please. So the model that we have to integrate services and to have a comprehensive package of services that also incorporates structural interventions is what we're demonstrating in this framework, where at the center we have KP leadership of all our mobilization, outreach, and risk reduction activities, but ensuring that the services we provide, and we look for a one-stop model where we have comprehensive sexual and reproductive health services, HIV prevention and care, and then adherence support as well, mental health support, sexual and gender-based violence services, adapting services for younger key populations, and community empowerment initiatives, as well as having monitoring and quality assurance. And we work not only with key populations living in Zimbabwe, but we have had initiatives for cross-border collaborations with Zambia, Botswana, South Africa, and Mozambique for the key populations from Zimbabwe that travel into neighboring countries. And one of the strengths that we have with the co-location model is working for public sector strengthening so that the model can transition into the public sector and be integrated over time. Next slide, please. So we've been working to scale up the program, but also just ensure that it is at the right intensity and providing effective services for key populations. And that has been led in the last couple of years by this micro-planning scale-up that I'm going to go into some detail about now, and building the capacity of key populations. Having these comprehensive services that I've shown in this framework I've just shown you, and ensuring at all times we're adapting, because we know that not all key populations are the same, not all male sex workers or trans or gender diverse people are the same. So at all times, we're trying to have a person-centered service and be adapting accordingly and having structural interventions that we're strengthening. Next slide, please. So I'm just showing here how the programmatic mapping works and how it comes to that micro planning at that micro level. We do have mapped in conjunction with peers, with the KP community, but also with stakeholders within the national level, the provincial level, and the district level. Where are the high volume sites where in this map for the sex work program, where there's high volume of sex workers in those sites? And then when we get into that site level, there's further programmatic mapping to identify where are these hotspots or where are these clusters of venues, or sometimes people are working from home or it's some street-based sex work. Where are those places? Then coming down to, from that hotspots that we've mapped, where are those clusters within these towns and these sites? That hotspot then gets mapped, and you saw in the slides from Paranita as well, an example of these maps that are drawn within the hotspots to see where are people gathering or where are they working that they can be reached. Next slide, please. So this is going into a little more detail about the micro-planning processes and roles. As I've just been explaining, we start off with that programmatic mapping where we are identifying the hotspots and then come into the individual hotspots. And when they are mapped, the peers will also be identifying who is in that hotspot by age band, by the typologies, and to try and see how many people are in this area that they might be working in. And it comes down to looking at how many within an age group, or how many males, how many females, so that whatever services are provided can be adapted to suit those people that are there. The micro planners, when they are allocated a hotspot, list every individual key population they find there in what we call a hotspot diary. They list them by name. And the ratios are similar to what's already been mentioned that comes from this global guidance. They're supporting cohorts for sex workers between 50 and 80, and we do have that maximum of 80. They don't manage to give good support when the cohorts grow much larger. Once they have their list of who is in this hotspot, they get to know them. They build rapport on an individual level. And once they have done that, they are able to have in conversations. It's not asked, you know, like filling in a questionnaire to say, you know, do you use drugs? Do you use alcohol? Or what does your condom use look like? It's after building rapport and in conversations with the people that they're supporting that they get to assess these. So we incorporated a risk assessment, and I'll show you what that a form looks like just now. And then once the micro planner has been able to assess, they will have classified the people in their cohort as either low risk, and they try and reach those people once per month, or medium risk, and they try and see them once every 2 weeks. But if they see someone who is high risk, then they are trying to see those people once every week, and they require a more intensive level of support for supply of commodities, for referrals, for making sure they get to the clinic when they need that. And we call that process where they have that frequent outreach contact, we call it their tracking. They also will speak with the people that are in their cohort about different issues. And these sessions, whether it's about pre-exposure prophylaxis or condom use, or another issue that this person is applicable to this person, it's guided by the manuals that they've been trained on. The other component that there is what we call a quarterly assessment. Because nothing stays the same within a person, their vulnerabilities can change from time to time. They may increase or they may reduce over time, and you have to adapt the support you're giving to the individual KP accordingly. So once every 3 months, they're trying to repeat this risk assessment process. Another process that happens periodically, and we have done it at sometimes at 6 months, or when there's less resources, at least once a year at a minimum, to return. And so this is why you have the cyclical process to that programmatic mapping, because you have to come back and see, has things changed in this hotspot? Some hotspots may have closed over time. Maybe there's been a change of economic activity in that area, a mine has shut down, or there was something else that was drawing people into the area. But hotspots change over time, and individuals change over time. So this is why we have to have this cyclical process. It is continually being refreshed. Next slide, please. So how do we select the microplanners for outreach? And as had been mentioned already by Perry, that we are having to equip those that had been doing the generalized mobilization of services and peer education to be able to understand their hotspots really well, to generate maps, to generate data, and then to use that data to plan how they're going to execute their outreach and support their peers. The way we're selecting these peer outreach workers, who we call microplanners here, is they're well networked within that hotspot. And there are people who have good uptake of clinical services, but they know the people and have good relationships, because it won't work well to appoint a microplanner who doesn't really know many people within the hotspot, or who does not have good relationships with local stakeholders. They're equipped with training, and we start off with a 5-day training. And then there's also ongoing support and mentoring. Refresher trainings are important, but we have found funders are not always keen on supporting refresher trainings. So sometimes that's a bit difficult, but they are really important. Even HIV prevention landscape changes over time, and the microplanners also need refreshers around this. And I've just given you a summary of how the scale up has happened over time. We piloted in Zimbabwe in 2017 in the capital city in Harare, where we had 50 microplanners, and we still had the generalized peer education in all the other sites. And over time, we've scaled this up, and we now currently have 645 microplanners across all sites. Next slide, please. So I'm just showing you here an example of mapping data and remapping from intervention sites in what was called the Amethyst trial, adapted microplanning to interrupt HIV transmission trial. And it just shows you that within specific hotspots, you can see that population size estimates change over time. And in some of these sites, the areas that had been mapped, the size estimate has reduced over time for various reasons. And when this mapping is done, there's quite a lot of extensive detail that is also gathered. But we don't have time to go through that now. That will explain changes that have been noticed by microplanners and peer supervisors who validate the mapping to explain what changes they've observed over time. Next slide, please. This is the risk assessment tool that I've mentioned earlier, where we're looking at these factors that are likely to predict risk of either HIV acquisition or transmission. So the microplanners will assess whether there's new entrants into sex work, inconsistent condom use or high client numbers, and then assess them according to the risk on this tool. Next slide, please. So what I'm showing here relates also to that sample of 11 sites with their mapping data. It then sets what is the target. We then get a sense of how many people are in these locations that we're trying to reach. And so this is showing you the target, this sort of dotted black line of the mapping data. As the size estimate was changing over time and increasing, we would be updating the target, and then we would be tracking how far are we in reaching them. These outreach contacts are based on, as I said, the individual. Do they need to be reached once a month or 4 times a month? So you can see that that also varies, and there is an impact on how frequent outreach contact is possible with certain contextual factors. It really was quite hit hard in March 2020 and in the months that followed that with the COVID pandemic, and we had some very strict lockdowns and movement became difficult. And so peers who had been contacting those who they support in person couldn't reach them. We've since had some adaptations over time to be able to have some virtual outreach where it's possible, and they can follow up peers over the phone or on WhatsApp and find out what they need, and then make arrangements if they need lubricants or condoms, for example, to get them to them. So those adaptations have helped, but in the beginning when they weren't in place and when we didn't have funding for data and airtime, it didn't work as smoothly, and we definitely saw some very significant dips in outreach contacts. Next slide, please. This is just showing you some of the manuals that are used. This is one of the older manuals for the sex work program. And we have adaptations all the time when we realize there's a gap or there needs to be some differentiation of materials. So for young women selling sex, they have the manual that is used by the peers is known as the Girls Club Manual, and that was adapted. And the sessions are tailored specifically to those needs. Next slide, please. Paranita has already talked about this document. It was just to say we're trying to really rely on what we've learned from other implementers and other countries. We also had learnings from Kenya, but we also look very much within the global guidance. So it's really useful that we have these tools available to us. And I'm just encouraging that when you look at how to adapt for a local context, we really do make use of these guidelines. So for example, there is the recommendation on what ratios to have for peers to KPs, and even for supervisors to the peer educators, outreach workers as well. Next slide, please. So I did want to mention, I'm wanting to mention a couple of things before I round up, that we found really sort of enhanced and improved the model with the micro-planning. So each micro-planner was trained on running self-help groups. And these are run within the cohorts that they're already micro-planning. And they bring together between 12 and 15 members who come together and decide the priorities that they identify within the group and what they would like to work on. Sometimes these have been economic activities, and they have started up enterprises, and it varies across districts, but some of them really, there's been a lot of increase in financial resilience coming out of these self-help groups. Where there used to not be good relationships, social cohesion, we've also witnessed with the self-help groups. They've really worked well. And we've also seen an improvement in engagement in services among people who are members of self-help groups compared with those who are not in the self-help groups. So it's really something which I think is worth considering incorporating into those programs. Next slide, please. This is just in the image there. Self-help groups also became more than platforms for gathering for social cohesion. They've also focused within a lot of the groups on stigma reduction. And some have formed community art refill groups that we previously had difficulties with because of distrust and fear of stigmatization within the sex worker communities. So we found that to be really helpful. On structural interventions, peers are also leading mental health services. We are using the friendship bench model for problem-solving therapy, and we have what we call friendship bench buddies, which are KP cadres trained as lay mental health counselors. And in the last year, they provided therapy to 3,594 KPs. Next slide, please. We've been working with community-based organizations to build capacity of nascent community-based organizations, including ZRC, Trans and Intersex Rising, TransSmart, and WAD. And then the other component that we've been working on is how to strengthen career progression. So if we go to the next slide, I'll explain a little bit about our career progression model. Next slide, please. Thank you. So we have what we call the career pathways for community cadres. Otherwise, we did find if we're not deliberate about it, it's very possible that someone remains a peer educator or a microplanner for life, because we have had, structural issues that prevent them from progressing and attaining skills. And if we don't deliberately address that, then we box them into that place. So what we first do is define what are the jobs within the program. We have the organogram of the program, and whether it's a coordination or M&E work or data entry, those are very clear. Then we have all the community cadre roles defined, so that when community cadres are looking at what's available, they chart what they want to do. Then we identify what their individual training needs are, and we support those. And there's been various opportunities that have come on for vocational skills training or tertiary education, or sometimes it's secondary education they're needing. And that has also then ensured that they've got the skills required to do the work. And then we have prioritized KP applicants whenever there are roles coming up, especially within the program work. Next slide, please. So I'm just ending off by summarizing what's been important for us. It's having that foundation of the comprehensive HIV prevention and care services available. Always in whatever component of work we're doing, having KP-led mobilization and empowerment, and ensuring that we do have effective coverage with the peer support. We've not neglected structural determinants, because that often can be a barrier. And we've had capacity building of KPs, but also of their organizations. And we've had clear career pathways for progression, and that the self-help groups really are also very important for improving social cohesion and economic strengthening. Thank you, Humphrey. Over to you.
Thanks, Primrose, for that very eloquent presentation and for sharing the science at community level of how we can improve outreach models. I want to open this opportunity for colleagues to interact with the three presentations. Please show by raising your hand or unmuting yourself and sharing really what your question is or your contribution to this discussion is. May I also invite Pari and Janet and Primrose to look at the chat. In a minute, I'll come back to you to speak to any of the issues that have been raised in the chat so far. Any questions? I'll look at the hands, if there are any hands. If not, feel free to unmute and come through. I see a hand from Sabino. If you can come through, Sabino, over to you.
Yes, Humphrey, thank you for the opportunity. This is Sabino from Mozambique. I'm the Lobbying Advocacy Advisor from Lambda. Lambda is one of the LGBTIQ organizations here in the country. I just wanted to congratulate both presentations. I actually don't have a question as such, but I was interested to understand like the key population groups in both, I don't know if I'm mistaken, but in both presentations, I couldn't see or any mention to people in prison. Does it mean that they are not part of the KP population? So this can either serve for both or at least one of the presenters. Thank you.
Thanks, Sabino. I'll take a couple of hands. Thank you, Sabino, for that contribution. Any other hands? I am not seeing any hand at the moment. So while colleagues are still warming up, can I invite, let's start with Pari. Pari, if you can unmute and maybe address some of the issues that have come up in the chat. And then we'll have Janet and also Primrose.
No, thank you, Humphrey. I think the way we try to design this Link and Learn session was to talk about the global, the national perspective, and the implementation perspective. So I do hope everybody got a sense of how communities involve in the real context from Primrose's presentation. And of course, the involvement of community need to be guided by policy and guidance document. And Janet shared about how Kenya has developed these policies and guidance document, which allows for community-led outreach and engagement of community. We have to make selections. So we could have selected also a KP-led organizations here, but there are so many other conversations happening. There's another conversation happening between Kenya and Ghana about PWID, where a lot of key population are engaged. There were 2 or 3 questions about training of key populations, and there are a lot of resources now available. So I would request everybody to go to the GPC website, where they have a repository of all the training materials and all the documents from different countries. And you will find, I have put some in the link. There was a question more specific to the remuneration, I guess, for Kenya, which I'm sure Janet will respond to. There was a question on standards. So I have put a link from Kenya. It's an old document, 2010, but nevertheless provides a sense, and it's getting revised now. So yeah, so that's what I can say. But to specific question of Sabino, I will leave it to Janet and Primrose.
So thanks, Perry. I noticed there was a question that had come through around the specific service packages within the global guidance for the different KP communities and what guidance is there. And I really wanted to urge colleagues to settle back to the different implementation plans that have been developed for people who use and inject drugs, for people who inject drugs, for sex workers and their diversity, for many of sex with men, and for transgender persons. And those are very, very resourceful documents that you can always reference in our implementation. Janet, over to you.
Okay, thank you. Thank you so much. There was a question about whether people in prisons are not part of the key population. In Kenya, we have what we have the key and vulnerable population. So for the key population, we have the 4, where we have the FSW, MSM, transgender people together with PWID. The people in prisons are under the vulnerable population, but still under the national program for key and vulnerable populations. I hope that answers your question. Those question on clarification on the enumeration. The enumeration for the peer educators between 6,000 and 7,000, and was able to share that other than this, the other like airtime and transport that is also reimbursed by the different partners. And then for the For the outreach workers, it's between 10 to 20,000 for the PWADs, and up to 12,000 for the FSW, MSM, and transgender population. I hope that clarifies, because I'm hoping the 26,000, that was a typo, seeking clarification on that. There was also a question on about the presentation, and I think Pari was able to clarify where the question was, that this presentation is basically led by the government, but there was a question about the capacity building, and I was able to respond to that. Capacity building initiatives are led by the KP community. They are part of the development of the curriculum, and they are then the ones trained as TOTs, and the ones who go and conduct the trainings to the rest of the implementing partners and to the rest of the community. I think those were the key questions. The others was a request for the 12 standards that has been shared. I think that's it. Thank you.
So I'm still keen to open the floor for further questions. While I'm doing that, Primrose, do you have anything to speak to or to follow up?
Yeah, it was just on the question around people in prison. They are included in key and vulnerable populations, as SESHA we're not implementing for prisons. And I think that is an area where there's sort of need for more strengthening in our implementation. But they're definitely defined as a vulnerable group. And then I wanted to just mention, there was a question around how we deal with legal environments, especially, with the criminalization. And I think that there's two things. The first being that working with Ministry of Health and with National AIDS Council definitely provides, I don't know if we call it a protection, but certainly when you're navigating programming at a national level or a provincial level, you will sometimes encounter people who have attitudes that are negative towards key populations, and who are of that leaning of, these are even criminalized groups. But when it is within national policies to be able to provide services to these groups, and there's the frameworks for it, that has been very helpful in facilitating, providing services, and in empowering the communities. And that facilitating of setting up the Key Populations Forum, I think, has also helped that. Separately, there's also been, among key population groups, engagement with the legal environment assessment process that was being facilitated with UN agencies, and being able to advocate for the recommendations that came out of that legal environment assessment process. So there is some engagement as well with the legal environment. And then lastly, it was just, I think there was a comment around that most of these programs are government programs. And so how is there going to be movement building for key populations, or building capacity of key populations, and ensure that they end up well represented? And I think that we are seeing over time this happening in Zimbabwe, but it definitely takes deliberate effort. For example, there's now leadership of the KP Forum by key populations. And there are organizations that are being strengthened in capacity and are implementing now, and some as sub-grantees, and further capacity building for them to implement as prime organizations. So even where there is a government-led program, deliberate transfer to key populations, I think, has been possible here. Thank you.
Thanks, Primrose. And I think from a Zimbabwe perspective, I also want to add that we have a Public Health Act that ensures universal access to healthcare for all Zimbabweans. So particularly speaking to provision of non-discriminatory healthcare services. So this Public Health Act is very important in what Primrose calls navigating an otherwise challenging terrain. We have seen in the past couple of weeks incidents of disharmony with particularly KP issues, LGBT issues in other countries like Kenya. And we know that when all these things happen, our communities go underground and become difficult to reach with services. But if you have a government initiative that is the one that is supporting the provision of healthcare services, you are assured that there is protection of the gains and the communities can still access services in spaces that are assured of safety and security. So I want to take a couple of more hands before for the next 10 to 15 minutes so that we sort of hear from you colleagues a lot more around reflections on this. There's been a lot of resources that have been shared on the chat box, and we will also make sure that some of these resources get into the package that we will be circulating to all of you. So by show of hands, would there be colleagues that are interested in asking questions or contributing to this conversation? I see Grace Kumwenda, please go ahead.
Thank you so much, and thank you to all the presenters. It's really been enlightening to hear from all of you. So my question is still around stipends or remuneration for peer educators. And I just want to hear from your experiences, both in Kenya, but also Zimbabwe, in terms of how are you striking a balance between getting adequate peer educators to reach coverage vis-a-vis remuneration at an adequate amount. I ask this question because in Malawi, where we're coming from, we were initially paying a stipend that was a bit lower, and that allowed us to have a lot of peer educators. And so coverage was quite easier to reach, I should say. But over time, with the need for us, when you look at the economic situation, the need for us to pay more to remunerate better, we've had to also start looking at how do we find a balance along that. So it had meant that we had to get kind of lesser numbers of peer educators than before. And I think this is an area that we're now starting to think around. How do we start pushing for coverage despite the numbers that we have? And I just want to hear your reflection in terms of what's happening within your countries. Thank you, Ova.
Thanks a lot, Grace. Any other question before I ask Primrose and Janet perhaps to jump in with this question? Sharing experiences from Zimbabwe and Janet, how Kenya has come up to this harmonization of incentives for outreach workers in Kenya and how that has worked. And particularly to speak to, the different support modalities across partners. We have programs that are Global Fund supported, programs that are PEPFAR supported, programs that are supported by different foundations, and programs that the core government of Kenya itself or the government of Zimbabwe may be supporting in terms of peer outreach work. And these tend to remunerate the peer footprints differently. How did you navigate these conversations in Kenya and arrive at a harmonized approach? Janet, over to you.
Okay, thank you. It is ideally a consultative process. And as I'd indicated, in Kenya, we have a coordination mechanism for the national program. And this is basically through the technical working group meetings. And in the technical working group meetings, we have donors present, we have implementing partners present, we have the community present in that. So what happened is that we had quite a number of consultative meetings, just able to look at what are the different donors providing for their peer educators in terms of whether it is stipend, whether it's type of transport, whether it's time of airtime, and then just coming together and having a discussion and agreeing what is then feasible as a country. And I think this is a very key step, because once that as a country, you are able to agree and get a harmonized amount. And what happened is that if you noticed in our country, we had a range that it is a range from this to this, so that then partners are able to pay between a certain range, but not below a certain amount. And by doing that and having this then stipulated in the guidelines, we found that it has been easier, especially when now proposals are written and when we have the COP and the Global Fund coming in, we have guidance or we have documents that we can look at and say in our guidelines, this is what we're supposed to be able to work with in terms of enumeration. And that has really eased the way in terms of ensuring that we have standardization in the programs that we have. But it does take a lot of consultation and just having an agreement and seeing what works best for you as a country, and not that would not then jeopardize the quality of services that will be provided to the key population program. Thank you.
Thanks, Janet. Pari, do you want to jump in and add to this conversation?
Yeah, I mean, I think Janet said very clearly about the policy and guidance, because then that becomes a point for advocacy with different funders. And I think the question that Grace raised is very, very real. But in Kenya, I also found what has worked is the community advocacy that the KP community do themselves. I remember around 4 years back, because Kenya does peer conventions on an annual basis. On 4 years back, the peer educators came and advocated very strongly for the remuneration package to change, and the government actually developed, in consultation with the funders, developed a policy and changed the remuneration. Truth is that for a practical reason, it was a range. So which means that the funders are allowed to give the lowest or the highest. But I've also seen some funders, especially like Global Fund, who are able to provide not only beyond the remuneration, mobile currency or mobile airtime or travel. And I don't know if Khalda Mohammed is here today to explain how they do it. But Grace, I think we keep advocating for it, but I just wanted to raise my hand to say that the community advocacy also works very, very strongly, because key populations have been able to change policies, and key populations have such a strong voice in the COP process or in the GF proposal development process, that space they should utilize for some of these advocacies also. Thank you.
And I think this is a very timely conversation to have as we are getting into this planning process, both with the Global Fund and with PEPFAR, so that there is an agreement on how we approach the remuneration, basically for a lot more cadres, even beyond, the outreach workers. And we appreciate, maybe Primrose, if you can get into this, that the range of the work that colleagues as peer outreach workers get into is different, from basic peer education and graduation into other sophisticated or more challenging, risk differentiated microplanning techniques and workloads. We are getting an interruption from Stephen. And risk differentiated microplanning, it demonstrates that the work is not uniform across all cadres. And the added layer of interventions, if you add an intervention that an individual maybe follows up a cohort of clients for retention on art or on prep, or follows through a support with a mental health screening, etc., that is an added task to someone's job description that you need to remunerate differently. I don't know, Primrose, would you like to speak to how you've approached it as Sesha?
Thank you, Humphrey. So how we have approached it is at the stage of proposal development and negotiating the budgets. So being able to see that we were shifting, for example, from peer education to microplanning, and the stipend that was paid for peer education without these enhancements with the microplanning was US $15. And then with the microplanners, they are receiving US $50. But you know that the amount of work is vastly different. And they have these cohorts which are fairly large to get to know person to person and provide support for individually, assess risks, try and see someone sometimes every week. And they end up spending quite a lot of time than they used to. It's not anymore that whenever they get to their hotspot, they would distribute some condoms and try and, you know, just get a sense of everybody, whether they've got what they need. And they can end up spending anything between 2 to 3 days equivalent really in a week. So I think we have a difficulty where we sometimes are looking at community cadres as free labor or cheap labor, and that's a problem because they are doing a lot of work. So at the moment, we are very well covered in terms of the coverage because we did have that approved at the start of the grants that we currently implement for PEPFAR and also for Global Fund to have these US $50 paid for all 645 across the 2 main funding partners. But there's been a lot of discussion about whether that can be justified, especially with some other implementing partners who are micro-planning for MSM, but had a lower amount in the budget to try and negotiate for that to be increased in the middle of implementation. It's taken a lot of work and then finally been approved. So when things haven't been put in either with Global Fund or PEPFAR from the beginning, it becomes a lot of work and back and forth to try and get those changed because there's limited resources available. But I think we do need to just continue to hear the voices of the KP communities because they are doing a lot of work that we're not paying, you know, the equivalent. So some of it really is just in the interest of the communities because they're not paid for the number of hours they work. That is not the basis on which they're paid. Thank you, Humphrey.
So thanks a lot, Primrose, for sharing that. And I think I really want to belabor this another minute or so. And when colleagues were discussing just how much you pay and how you land with the right salary scale, we know that the funding pot is not growing any bigger. And every time we're confronted with increasing our targets and requiring even a greater footprint than we already have, we'll be saving. And in most of our cases, we will be introducing a service provision for a new KP population of people who use and inject drugs that are going to need to be working with an enlarged pot of people who use and inject drugs and the peer footprint from that. And we appreciate that the money may not be much to do that, and there may be squeezes here and there. What do you settle for reducing the numbers of the peer educators versus increasing and paying a reasonable salary, or trying to implore our governments to start picking some of these expenses from domestic financing initiatives? How are we navigating these kind of squeezes that we are seeing coming in this planning season or during this planning season? And Patty, if you have any recommendations, feel free to chime in. And this is open to the floor.
I might just come in there, Humphrey, to what you've mentioned about national governments, you know, coming in to pick up the gap, because over time, these need to be fully funded national programs. And that happens more so in some countries and less in others. And I think locally here in Zimbabwe, the National AIDS Council is now supporting in some districts, some micro planners. There's still some work to be done on having the levels of payment all the same across whether there's funding partners or government support. But I think that is important, that they are picking up that gap and that there's potential for local resources to ensure we maintain coverage at scale, because we can't start to create gaps again over time. It will take our gains backwards. Thank you.
Any experiences from Kenya or anywhere, colleagues? Feel free to chime in. This is open to the floor.
Just wanted to come in to say that, like you had said, I think timing is perfect, right? It's now or wait for another 2 to 3 years. COP process is also becoming 2 years now, right? And I feel like, I think everybody has a strong role. The government has a strong role for sure. The community members, the key population networks have a strong voice and a role. and so does implementing partners. And I think we have to have a common voice, and we have to have a common message when it comes to the donors. And I think, considering the fact that all donors say that they are going to be aligned to the national guideline, global guidelines, and talk about the national context, I think we have to just continue doing that advocacy. And I just feel that the time is right. I mean, today, the request for this Link and Learn has come from Global Fund, which I think also shows that the funders are open, and it's a matter of negotiation and matter of prioritization, really. But I think we all have to believe, and we all have to completely be committed to the fact that engaging and involving community in community outreach and community empowerment is as much important as investing in treatment, right, or drugs.
Thanks, Pari. I think that is very important, and for us to particularly leverage this opportunity to ensure that we have our us get into those proposals. Before we do a take of our final takeaways, I do want to indulge the colleagues who are working within the donor space. I see we have Ed online. We also have Clemens from UNAIDS. We also have Helga online. What would you share with us to strengthen, our community outreach approaches, particularly for our KP programs? And as we approach you, what do you want to particularly emphasize that we should be doing? Helga, Ed, Clemens, any of you can take this in a minute.
Okay. Thanks very much. And I think somebody has said that this is a very timely webinar, and basically this is a collaboration between SSLN and the country champions and Global Fund. And for us to really have come up with this is that we have the best interests of the countries and the communities at heart. And that's why we wanted practical solutions, practical considerations as we start the new grant, just because we know peer education is a backbone of our KP programs and the other hard-to-reach populations. I think in summary, for me, I would like to say the timing is important. I think Primrose has said that initially we've had difficulties really in Zimbabwe, moving from $15 to $50. It was a war, and it was just because of the timing, and I think she has contextualized that. So I think timing, and Pari has also raised the issue of timing being very critical. It's good to start these discussions when you're starting to plan either COP or the other Global Fund processes. Standardization, again, across the donors, because we have seen conflicts where we have PEFA or any other donor paying different from what Global Fund is paying, and we have seen peer educators not very happy and moving from one donor to the other. So it's very critical. And therefore, we ask the national governments to really lead the process of standardization across board. The issue of terms of reference for the peer educators, and I think, Humphrey, you correctly put it that it is beyond peer education. We are now using peer educators for service delivery. They are actually providing all the interventions, the combination prevention interventions, whether it is structural, they are doing paralegal, behavioral, they are doing all the behavioral work. Whether it is biomedical, they are also providing biomedical services. So really, we have now converted our peer educators, which is really good, to service providers. So we need to also consider that. But again, you need to look at the national context, and I think Pari has talked about that. We always talk about budget considerations, because at the end of the day, the envelope does not expand. So you need to get money out of somewhere for you to plunge into peer education. So what are you going to do? If you're saying you're using peer educators as workers in the program, are you willing also to reduce the program management money? So I think those are the basic considerations, very practical, that also programs need to look at. Peer ratios are very critical, and we have seen published documents from Kenya to show that peer ratios are commensurate to the increased access to services and quality of programs. So again, this is a critical area that countries need to consider. There is no need of providing a program that will not provide the coverage that will provide impact. So we will need to see peer ratios that are well thought out. And lastly is a peer progression. If we are talking about peers being service providers, then what are we doing? Do I still remain a peer educator forever? So these are the considerations, and I've had them very well articulated by all the members. But now let's put these into practice. You know, we have now had this webinar. What is it that we need to do for the countries that are in the one? What are the best practices that we can learn from each country? And I've had very good practices and a very good practical solutions that members are provided. So thanks, Humphrey. And I think I hand over to Ed to just add something. Thanks.
Thanks, Olga. Ed, if you're online, over to you. We may not have Ed online. Clemens, are you around? Do you want to say something for a minute? Do you want to encourage the teams that are here?
Thanks so much. No, really impressive to see all the work going on community outreach and peer education, which, as Helga said, is really a backbone of key population responses. And certainly we'd like to encourage you to continue supporting and expanding these important components as part of ongoing Global Fund and COP funding processes. And as Helga already mentioned, I'm not going to repeat it. It's important to have these kinds of programs at scale. And what we saw, for example, from Zimbabwe is really a model on how this can work at scale. One element to consider, of course, programs are evolving, and we have new options there in some settings with virtual interventions. And one can actually explore how those could be interlinked, and those provide an additional entry point, maybe not for all populations, for all settings, but in some settings can actually provide an additional entry point. And there's also material available specifically on virtual interventions. And I'm sure you've had other engagements that look at such complementary forms of outreach, which could also be having a strong peer-led component as well. So I'm not going to belabor this further and take more of your time, but just thank everyone, encourage you to advance this work, which is really important. And yeah, looking forward to seeing a lot of this work being included in upcoming prevention roadmaps, Global Fund grants, or COP proposals wherever needed to strengthen and scale up really key population responses. Thanks so much.
Thanks, Clemens, for those words of encouragement. We do feel encouraged that we continue with the work that we have been doing with all this within this partnership. And last but not least, shall we reflect on our takeaways? What is it that we feel we have learned? What are we taking away? Uganda, Malawi, Mozambique, and Tanzania. I'm going to invite one person from each of these countries just to share one thing that they are taking away from this Link and Learn session. Antonio, please proceed.
Thank you, Humphrey. So here is Antonio from Mozambique, TSU. So, it was very insightful meeting for us, especially to hear what the other countries are now doing in terms of the peer educators outreach. And some of the interventions are similar, some others are different. And one of the things that it's really challenging in the country, it is related to the, I don't know if it's right to say in English, remuneration, the payments that are being done for the peer educators. We did not yet harmonized it as a country. And we feel that it's really very important because we have different donors which are giving different package in terms of remuneration for peer education. And I think Elgar or other colleague has mentioned it, that some can miss the other because they need to be where there are better conditions for the work. So this is one of the things that it's really very challenging for us. And we are planning to harmonize this with another donors as a country. And it's action that it is ongoing with within the civil society organizations, the donors, and other stakeholders to see how we can overcome this issue. And definitely we have an harmonized, let's say, package for the remunerations of the peer educators. So in terms of the outreach as a whole, I think some lessons that we learned today, it's really on how you establish the micro planning, which it's also being, I can say, partially in the country. And then we also need to have micro planning that reflected all the interventions with the KP, in the country, especially on the micro planning for the peer educators. So in general, this is one of the issues that we feel that it was insightful on this meeting, and we are working closely with support of the colleagues from Kenya, especially, and we have so many support for this. And I would like to say thank you. We have most of the guidelines that we are implementing are inspiring on the Kenyan, and also we have from Zimbabwe. We also asked for it. So I think we are working, all of us, to have a better situation for the KP implementation in the country. Thank you.
Thank you, Antonio. And the next time I will give you an entire slot for a presentation. So if I can hear just for 1 minute from colleagues from Malawi, from Mozambique, from Uganda and from Tanzania, just 1 minute of your lessons, and then we need to be closing by the hour. It's 2 minutes to the hour. Any takers? Uganda, Malawi, Tanzania? What did we learn today?
Thank you. This is Dr. Chambade from Uganda.
Over to you.
Thank you for the great presentations. I think there's been a lot for all of us to learn. But the key take-home learning for us as Uganda is to basically the micro-planning approaches. I think as a country, we need to strengthen the micro-planning approach in terms of KP service delivery, particularly in terms of building the capacity and the understanding of the micro-planning, but also in terms of standardizing the tools that need to be used to support the micro-planning in the delivery of services. I think this is a key learning for us as a country. And I think it's something that we need to take up and strengthen. Of course, it has been happening, but to a limited scale. But also many of our service providers across country do not appreciate the micro-planning approach in terms of strengthening service delivery to key populations. Thank you. Back to you.
Yeah. Thank you, Dr. Kambate. Can I hear from Malawi, Tanzania? Any takers?
Hi, a quick one from Malawi.
Yes, Grace, please proceed.
I think for me, there's been so many learning points, but one thing that I can talk under a minute is basically the fact that we do have a lot of resources that are available. And I think through the presentations that have been done, there have been so many resources that have been referred to, including the WHO guidance and some of the other documents that Barry talked about. I feel that my takeaway is we need to take those resources from the shelf and start using them to improve the program. I think there's so much we can do. There's so much strengthening and improvement of the programs we can do by just going through those resources and starting to implement them. That's one of my greatest takeaway. Thank you, over.
Thank you, Grace. And I think you say it right at the point. We have no poverty of technical resources. There is guidance left, right, and center on these specific issues. Shall we hear from Tanzania? Any takers from Tanzania before we close? Going once, going twice. Thank you, God. So this is the end. This marks the end of the presentations and this session of the South to South Link and Learn hosted by Zimbabwe and Kenya on outreach approaches. The last thing that we will do, we have a poll that we take at the end of the session. So before you log off or before you log out, kindly do complete this poll that speaks to our Link and Learn poll and just a very short summary of how you experience this session and how we can improve in the future. I would like to take this opportunity to thank you all for the time you've taken, the SSLN team that has been working to pull together all these presentations and these sessions, and everyone that has participated, the presenters, the donors, and the community members that have joined this call to increase and nuance our conversations. We look forward to another exciting session that is forthcoming in a couple of weeks, and we encourage that you continue and join us for yet other upcoming sessions. You have a good afternoon and goodbye.
And thanks to you, Humphrey, for facilitating such a wonderful session. Thank you.
Thanks, Kari.